Retina Essentials for the General Ophthalmologist, and the aim of this session is to essentially look at a comprehensive overview of some common retinal pathologies and which can be identified easily by our ophthalmology colleagues, and how to identify some common diseases and some common patterns and manage them. So can I just invite onto the stage all of my co-instructors if they are here, Dr. Malika Goyal, Dr. Vinod Kumar, Dr. Abhilasha is already there with us, and Dr. Ashish Lal, if they are there, kindly join us on the stage. And in the meanwhile, without much ado, I know we are already running slightly late. May I invite our first speaker, Dr. Chaitra Jaydev. Dr. Chaitra is the head of Retina Services at Narayan Netralaya, and she will be giving us an essential overview on screening of peripheral retina in refractive disorders. Thank you so much for joining us, Dr. Jaydev.
Thank you, Mudit, for that kind introduction. Let's kick off. Thanks to AIOs for this opportunity. I'm going to speak on a very important topic, and especially so for general ophthalmologists and also for those doctors who advise patients for refractive surgery, because these patients are expecting a 6/6 vision post-op, and you don't want to take any risk. There's a whole lot of medical legal issues involved with not achieving that goal for these particular patients. A lot of them are very young, so you don't want any trouble with respect to retinal disorders. So I'll be talking about peripheral retinal degeneration, when to treat these patients, and also the recommendation for patients undergoing refractive surgery per se. Now, let's understand the terminologies. What is degeneration? It's a loss of structure. And you know, in the retina, there's loss of structure, function of cells in the retinal tissue itself. And then you have peripheral retinal degenerations and macular degeneration, which does not come within the scope of this particular talk. We'll only be dealing with peripheral retinal degenerations. So this is a classification based on the location of the lesion. We look at vitreoretinal lesions such as snail track, lattice, retinal tears. Intraretinal, where you see retinoschisis, snowflake, and WWOP is so commonly noted. And then you have chorioretinal. But most important are these vitreoretinal, which is lattices and retinal tears that we're going to see. Why are they important? Because they're very anterior, even anterior to the equator. Most of us are not very comfortable doing IDO. Not all of us have access to wide field imaging, non-mydriatic imaging, and most of them can predispose to rhegmatogenous RD, especially post-operatively, and especially because these patients have a very, very high minus power. Now, what are the common and important ones? Snail track degeneration. Why you need to know this is because they are very similar to lattice degeneration. You need to make sure that you differentiate between these two, and even these can be associated with retinal holes, which is why they're very important. Next, if you see the OCT through that, you see an irregular retinal surface and hyperreflective dots, which are basically lipid deposits. These are not really important for the diagnosis, but just to give you an idea of how they appear. So here is the OCT through that retinal hole. You can even see a cuff of SRF there, which means you definitely need to treat these lesions. Now, these are the different vitreous changes that we see. Next is your lattice degeneration. I think most of you would have seen the cigar-shaped lesions. They could be single, they could be multiple, associated with holes or no holes. They can be even oriented along blood vessels, atypical. When you see patients with sticklers and Marfan's, they are quite atypical in nature. So these are the ones that I'm showing you. You see these arborizing lines. Some of them are pigmented and some of them are not. This is the vitreous changes that you see. You can see the vitreous condensation over the retina in these particular patients. Now, retinal holes, again, you can see atrophic holes, you can see operculated atrophic holes, and you can see even atrophic holes with a cuff of fluid. So all of them definitely need treatment because they are risk factors for retinal detachment. I've shown you all the three different types of retinal holes here. Now, retinal tear. Now, this is important because it's a very dynamic lesion, which means there's an ongoing traction in these patients, which means you have to follow them up very closely and you need to treat them. There you can see the horseshoe shaped tear. This is not associated with the rhegmatogenous RD as yet, but big risk factor because there's a constant traction on the HST. Then you have the snowflake degeneration. This is innocuous, but you do see them in clinical practice. You just need to be aware of them. Paving stone, again, sometimes why I put up this is sometimes you mistake it for laser marks. So please be aware that these look like paving stone degeneration and this is not laser marks, and patient gets alarmed, like, why are you saying laser? I've not done, do I need laser? So it adds to the confusion. Good to remember it as a differential diagnosis. White without pressure, as the name suggests, it appears white even without causing the indentation. Normally with indentation you see it, but here you can see very clearly the white without pressure there. Very rarely is it associated with GRTs or giant retinal tears, so you may need to keep a close watch on them, especially post-operatively. So what causes RD? You have peripheral retinal degeneration, you're seeing a retinal detachment. What is the predecessor to this? It is basically a posterior vitreous detachment, especially when the vitreous is attached very tightly to any of these lesions. During the detachment or posterior vitreous detachment, which can occur normally, it can pull on these degeneration and give rise to a retinal detachment. So that comes to this symptomatic PVD that patients come to you. They say flashes or floaters. They can also see vitreous hemorrhage. You can see tears or even a retinal detachment very early in the course. But you need to repeat the examination 4 to 6 weeks later, especially if you don't see any lesions, because the PVD can take that long to complete its process. And when you see PVD with hemorrhage or pigments, more likely to have developed a retinal tear. So you have to wait for the hemorrhage to resolve and laser these patients as soon as possible. So when do you treat these patients? Let's look at an example. 26-year-old female, she comes for a routine checkup. You see that lattice there. Would you treat her? Show of hands. Would you treat her, Mudit? Just a lattice degeneration, no hole there. Patient has come for a routine examination, no symptoms, no family history. Then that's right. You don't really need to treat every single patient with lattice degeneration. But if she wants to undergo a refractive surgery, she's a high myope, she has a family history, there's a hole there, then you definitely want to treat this patient, because you'll never know what is the post-operatively. Unfortunately, what happens is most of these patients, once they undergo refractive surgery, they think that their retina also has become normal. So they don't come for a checkup. Especially if you're suspecting that this is going to happen with that particular patient, it's best that you treat them. Most of them travel abroad and come back after 3-4 years. So you want to make sure that they're safe. We don't have uniform guidelines to treat these sort of patients, because most of them are, Western-based studies, but there are medical legal issues, and we need to be extremely careful for our patients and do not take into account different clinical situations. You have to consider family history, previous history, refractive error, which surgical procedure. All of them are important. So what is the lesion? What are the vitreous changes surrounding that lesion? And what are the risk factors? So this would be a stepwise approach to these patients. Now, recommendations for screening and management. Should we treat all lesions? Let's look at our data. Between 2020 and 2021, we saw 3,000 patients undergoing refractive surgery. Lattices was present only in 285 patients. Laser was done only for 94 of them and not done for 191 patients. None of them developed retinal detachment. So are we erring on the side of caution? In fact, for a patient who didn't have lattice, developed RT. So I think we are being overcautious, but I don't think it's a bad thing, because you don't want to fight this in the court of law. So no RD again in these patients who even underwent laser. So recommendations, please note this: treat promptly all symptomatic, asymptomatic horseshoe tears, operculated holes, lattice with holes, and atrophic holes. These are mandatory treatment lesions. Others are recommended. You can base it on the other risk factors that I spoke about, like family history, refractive error, previous detachment in the other eye. All those things you need to take into consideration. So like I said, this is the ones that you need to treat promptly, with or without patient undergoing refractive surgery. Patient might say, I'll come back for laser when I'm undergoing refractive surgery. No. And most of them get confused that this laser is the same as refractive surgery. Again, you have to be very, very careful about that. When is the timing? Ideally, you have to do it after at least 7 to 14 days, because that's how long the photocoagulation takes. And re-examine the patient 2 weeks post-surgery, preferably. And studies have shown that the lesion, if a new one occurs, it's usually in the same quadrant as the previous lesion. Who should do the screening? Anyone who's comfortable doing a retinal examination. Use wide field imaging. If not comfortable, refer to a retina specialist. So to conclude, patients undergoing refractive surgery needs a thorough retinal examination, barrage laser whenever possible, and you should tell these people, impress upon them that you need to come back for a retina checkup, if not going to the refractive surgery department. Thank you so much.
Before we move on to the next, because just one question. So essentially, for all refractive surgery, if the patient is planning to go ahead and you see a lesion, you go ahead and advise a laser.
Yes, Mike, it's not on, I think.
So the question is that for all patients who are planning to undergo a subsequent refractive surgery, you will advise for a prophylactic laser for any peripheral retinal lesion.
I also want to add that my threshold is a little lesser for refractive laser refractive. But for those who are going lens-based, like these phakic IOLs,
yeah.
There I tend to be a little bit more aggressive in advising, because I've seen more tears and breaks after phakic than with
Yeah, the other reason is that phakic IOLs predominantly are done more in very high myopes.
Exactly.
So the vitreous changes
Risk is
and are much more
higher.
in those eyes.
Yes.
And the detachment also are more difficult to treat for these eyes.
Absolutely. Absolutely.
All right. So thank you so much for that.
Thank you. I need to leave for another session, so thanks for the opportunity.
Thank you so much. And now may I invite our next speaker, Dr. Mallika Goyal. Dr. Mallika Goyal is Head of Retina Services at Apollo Hospitals, Hyderabad, and she will be talking to us about recognizing and managing vein occlusions.
Thank you, Dr. Mudit, and to Dr. Tinku Bali for this opportunity. So I'll keep it basic as I was asked to. When we see retinal vein occlusion, the first thing to look at and address is any comorbidities. Any hypertension, which is the most common comorbidity, diabetes, lipids, tobacco use, very important, homocystinemia, in more atypical cases, blood malignancies, and inflammation. And then we come to ocular therapy after addressing those issues. The first line therapy is serial anti-VEGF injections, and only then comes laser, steroid, or vitrectomy in specific cases. So first is systemic management, and only then is injections. Now, when we examine the eye, the most common ocular comorbidity and the risk factor for causing retinal vein occlusion is glaucoma. So look at the disc very carefully. It's very easy to miss early changes. And avoid steroid injections for the macular edema associated with RVO because IOP may rise. And likewise, for managing glaucoma, avoid the use of prostaglandin analogs and alpha agonists because these can increase the risk of recurrent macular edema with RVO. So as I mentioned, glaucoma is the commonest ocular morbidity but easy to miss. Examine the disc very carefully in every patient of RVO. It can be classified as central retinal vein occlusion or hemiretinal or branch. And central and hemiretinal can be ischemic or non-ischemic. Branch retinal vein occlusions can be one of the major veins or a macular branch vein occlusion. Now, ischemic CRVO and HRVO will present as a drastic vision loss, usually close to counting fingers at 3 meters or 6 meters, not better. Extensive hemorrhages, severe macular edema, higher rate of macular edema recurrence requires more injections. And sometimes there is not even much edema, but the vision is poor because of the severe ischemia. And most importantly, these eyes need vigilance for development of neovascularization of the iris and NVG, which is a very devastating condition. In contrast, non-ischemic CRVO and HRVO do not have such a poor presenting vision. Visual recovery is good and they need less number of injections. Now, HRVO is diagnosed when there are two quadrants involved, either superior or inferior. And in these patients, the significance is because the extent of involvement is greater, there is a higher risk for neovascularization of the iris and NVG. So this is a major branch vein occlusion, superotemporal, which is the most common, or it can be a macular branch vein occlusion. In macular branch vein occlusion, there is no risk of proliferative retinopathy because the extent of ischemia is very low. Now, what are the complications we may see in retinal vein occlusions? Initially, of course, the macular edema, which we start treating with injections. But later on, proliferative retinopathy in BRVO. Look for NVE, NVD, vitreous hemorrhage, and tractional retinal detachment. And for this, it's very important that every patient of BRVO is committed to an annual retina exam. It has to be told to them that even if vision is good, you have to come for an annual retina exam. As you see here, patient is asymptomatic, superotemporal BRVO with pre-retinal vitreous hemorrhage, and this requires scatter laser. Similarly, a patient not aware of any symptoms, but you see the NVD and requires scatter laser in BRVO. So every visit, look at the disc carefully and the periphery for new vessels. In CRVO, HRVO, we have to look at the iris very carefully and the angle gonioscopy for early signs of NVI, NVG. Now, what are the investigations required? The role of fundus photography is generally underestimated. If you see this, if you just see the OCT, there is no change. Vision has also not changed. But the hard exudates are increasing, which means that we need to be more aggressive in the treatment. Similarly, again, the OCT and vision have not changed much, but hard exudates have resolved, showing that treatment is helping the patient in some way. And similarly, macular hemorrhage cannot be captured by any other modality except by fundus photography. OCT angiography has taken over the role of fluorescent angiography and is non-invasive. It can pick up the extent of non-perfusion, any new vessels on the disc, new vessels elsewhere. So the role of fundus fluorescent angiography really remains to document the type of leakage to allow macular laser in BRVO most of the time. Also, in cases with hazy media, it can allow us to detect new vessels because fluorescent can allow us, may not be possible on photography or clinical exam. Fluorescent may also show up new vessels on the iris which were not suspected. Treatment is anti-VEGF injections, and this is the list that is now available, and steroids, 2 of which are available. Anti-VEGF injections are the first line of management because steroids have these 2 major complications, raised IOP and cataract. Which anti-VEGF? Well, there are many studies done recently. The SCORE study, the LEVO and the Newton study. All of these comparing aflibercept to ranibizumab and bevacizumab and finding that aflibercept gives superior results in terms of efficacy and duration of action, reducing the treatment burden significantly. When to consider steroids then? Is there any role at all? I think the only role is when anti-VEGF are contraindicated, such as in pregnancy or recent cardiovascular events, or there is a severe renal dysfunction where anti-VEGF can worsen it, or when there is traction with active neovascularization where anti-VEGF can worsen the traction. What's the role of macular laser? This has a role only in branch vein occlusions for macular edema, but no role in CRVO or HRVO, possibly in HRVO in some cases. Scatter laser definitely is mandatory for all patients that have neovascularization. All patients with RVO have to be examined either annually or 6 monthly, depending on the severity and extent of ischemia. Each examination, intraocular pressure, undilated slit lamp exam of the iris and angle, especially in CRVO and HRVO. Look for glaucomatous disc at every visit, NVD, NVE, peripheral hemorrhages, traction, which can be easily missed and require laser, scatter laser. And very important, fellow eye examination. Very often there will be a silent RVO in the other eye. When CRVO presents with a disproportionately poor vision, there could be an associated cilioretinal artery occlusion, which makes the prognosis poorer. And this is the last slide on retinal vein occlusions in the young. Generally have a good prognosis, mostly idiopathic inflammation, though there could be an infection etiology. More commonly, blood dyscrasias, homocystinemia, or medication, including oral contraceptive pills. Generally, they need just 1 injection and they recover and do not need any more treatment and get good visual acuity. We also had a few cases post-COVID infection and post-vaccine. Within days of Covishield in a young lady and within 11 days of Sputnik vaccine in another young male. And the first one resolved without any injection and the second one did need injections. Thank you.
All right, thank you so much, Dr. Goel. Great talk and great cases. So just a question which probably will help all our colleagues over here. So the first line of treatment whenever you see a vein occlusion is essentially anti-VEGF agents.
First, as I said, find out what's the cause.
Yeah.
Whether it's hypertension and it's totally uncontrolled, patient is unaware. So first is to find out the risk factor. Before that, there is no touching the eye. Once we have identified and the patient has started management for that, optimal management, then yes, anti-VEGF.
All right, so thank you. So I think that's a very important message for everyone. It's important for a good systemic evaluation and for identifying the underlying systemic cause for why that vein occlusion has occurred in the first place and then going ahead and treating the eyes. Often as ophthalmologists, probably we end up missing out on the fact that we also need to take care of their underlying systemic conditions. So that's a very important point coming out from this talk. So thank you so much.
It's my pleasure to invite Dr. Mudit Tyagi for the next talk on common posterior segment inflammatory conditions. Dr. Mudit is a senior consultant at the L.V. Prasad Eye Institute, Hyderabad.
All right, thank you so much, Abhilasha, Dr. Mallika Goel, and the entire team at AIOS and the scientific committee for having this instruction course. And what I will be talking about is basically common posterior segment conditions, inflammatory, infective or non-infective, which can be identified easily by all ophthalmologists and which can be initiated as far as the treatment is concerned. And the most important point, first of all, is to identify these conditions. So I'll be focusing on how we can identify some of these common patterns clinically. So the first thing whenever we see any ocular inflammatory condition is to first of all determine whether are we dealing with an infective or a non-infective cause, because obviously the treatment will be different. While it's just non-infective, then our main armamentarium of treating these diseases is essentially steroids. But if it is infective, then the most important step is to initiate an appropriate antimicrobial treatment. And therefore, the first step has to be identifying and differentiating between an infective versus a non-infective underlying etiology. Now, moving on to some of the common infective organisms and common infective retinal inflammations that we can see in our clinics. The first thing, like I said, and this is something which I keep on telling in all talks on pattern recognition, are first of all differentiate between the level of involvement. Are you dealing with a retinal involvement or are you dealing with a choroidal involvement, meaning thereby choroiditis? Now it's easy to identify clinically. If you see a lesion which is superficial and which is obscuring an underlying blood vessel, then it becomes easy for us to understand that this is a retinitis lesion. Whereas if a lesion is deeper, then you will see it deeper, number one, and number two, you will be able to see a blood vessel coursing over those lesions. So if you see blood vessels coursing over lesion, it becomes self-explanatory. It's intuitive to understand that this is a choroidal lesion which is pushing things up, and you can see an overlying blood vessel over this. So deeper lesions with blood vessels coursing over them, choroidal. Superficial lesions which are obscuring the blood vessel, retinal involvement predominantly. So the other point to remember is all retinitis is infectious unless proven otherwise. So whenever you see a retinitis lesion, you start with the premise that there is an underlying infection and you need to identify and rule out infections before going on to anything else. So the most common unifocal retinitis that we will encounter in our clinics is ocular toxoplasmosis, and this again is a disease which can be easily identified. So if you see a unifocal retinochoroiditis lesion, you can see these chirally plaques and this occlusive vasculitis. Think of ocular toxoplasma. So it's the most common cause of infectious retinitis in our clinics, most common cause of unifocal necrotizing retinitis, also one of the most common causes of membranous vitritis, and a lot of times you will see a dense significant vitritis, so what used to be classically described as headlight in fog sort of an appearance. So if you see a dense vitritis, but beneath that vitritis you are able to appreciate a single retinitis lesion, then that is toxoplasma. If you see a dense vitritis but you see peripheral lesions which may be confluent, then think of acute retinal necrosis. These are the two most common causes of dense vitritis. Also remember, if you see a lesion adjacent to a scar, so a retinitis lesion adjacent to a pigmentary scar in most cases will end up being an ocular toxoplasma. So unifocal retinitis lesion like what we just discussed right now, they do not have any consistent direction of spread and can be having a neurosensory detachment when you do an OCT. You can have arterial plaques and sheathing. Remember the pattern of recurrence. So most of these lesions recur from the edge of an old scar. So you see a scar, you see a retinitis lesion adjacent to it, your diagnosis becomes fairly simple. You are dealing with ocular toxoplasmosis. Compared to that, if you see a recurrence from the center of a scar, so you see a scar and you see a recurrence in the center, then it probably is tuberculosis. So these are two patterns. Tuberculosis lesions recur from the center of a scar. Toxoplasma lesions have a recurrence from the edge of the scar. And if you identify them, you will be able to pinpoint etiology of the disease in most cases. So let me just show you this one case. This was a patient who was initially treated as a viral acute retinal necrosis, was given intravitreal ganciclovir also once, was also treated with oral valacyclovir. But when the patient came to our clinic, what we saw was this area of retinitis in the periphery. But the important clincher was that there was a scar adjacent to it. And just now we said that a lesion adjacent to the scar is probably a toxoplasma. We started this patient with Bactrim DS and see how the lesion starts regressing. Now that is another point which we need to, as ophthalmologists, learn to identify the signs of resolution. So when the lesion starts becoming regressing, the margins start becoming more well defined, the vitritis is decreasing, those are the signs of clinical resolution. So while if you look over here in the earlier photograph, you can see these obscure, hazy, diffuse margins. As the lesion starts regressing, the margins start becoming more and more well defined. So this is how the patient responded after starting the patient on Bactrim DS, and this is how the patient was subsequently. So identify the pattern: retinitis lesions adjacent to scar, toxoplasma. Serpiginous-like choroiditis, again another pattern which can be easily identified. You can see these lesions over here which may not involve the peripapillary area. You can sometimes see unifocal lesions. Usually unilateral, can also occasionally be bilateral with this pigment clumping. Again a clue to underlying serpiginous-like choroiditis, and you know the etiology over here in most cases is ocular tuberculosis. CMV retinitis, again a disease which can be clinically identified. So you can see these retinitis lesions with central hemorrhages. Think of CMV retinitis. Also, while we presume that these happen only in seropositive patients, it's also important to remember that they essentially happen in patients who are immunosuppressed. So if your patient is taking long-term immunosuppression for any reason, if the patient is post-transplant or on immunosuppression and you see these lesions, your diagnosis becomes fairly simple. You are dealing with a case of CMV retinitis. What is another point which we need to remember is that these eyes will not have a very significant AC inflammation, and the reason is that your patients are so immunosuppressed that they are not able to mount an adequate immune response. So when you see retinitis lesions with an absence of associated AC inflammation, that's a clue to the fact that you have got an immunosuppressed or immunocompromised patient, and those patients then need to be investigated accordingly. Check for their immune status, check for the CD4 counts, check for HIV status, and you will know that you are dealing with a case of CMV retinitis. It has its own characteristic patterns, like I said, so extensive retinitis with these hemorrhages, a frosted branch meningitis, all of those are clinical clues which can be easily identified just on a good indirect ophthalmoscopy as a case of a CMV retinitis. Another common disease, acute retinal necrosis, again predominantly a clinical diagnosis, can happen in immunocompetent as well as immunocompromised host. You may have a moderate AC reaction, but you can also have a significant vitritis. These lesions are predominantly spread in the periphery, and then you can see these coalescing confluent retinitis lesions. Frosted branch meningitis, another pattern which can be identified, and what we need to remember is that frosted branch meningitis can happen in these few cases. It can be idiopathic, can happen in HIV positive patients. It can also be a clue to sarcoidosis, lymphomas, leukemias, and SLE, and therefore it becomes important for us to identify these patients. You see a frosted branch meningitis, if you are not able to find a etiology, it's always good to get a complete blood picture as well as a peripheral smear done. We have had 2 cases where lymphoma is presented with this sort of a lesion over here. Another common clinical pattern which we often discuss in uveitis circles is ocular syphilis. Now this is a disease which earlier we thought had gone away from our clinics but has now come back with a vengeance, and these are very classic patterns. So if you see a placoid chorioretinitis with infiltration more at the edges of the lesion, if you see this ground glass retinitis with a central clearing, or if you see these multiple medially lesions, these can be a clue to underlying ocular syphilis. It's not necessary that if you see these medial lesions that's 100% syphilis, but the moment you see these lesions, it should set your bells ringing and you should entertain the possibility of a differential diagnosis of ocular syphilis being one of the causes. I'll just take 1 more minute for this. So if you do an OCT through this placoid retinitis, you will see this RP nodularity, and an OCT through these miliary lesions may show a full thickness retinitis. If that's there, it kind of clinches it to be possibly a case of ocular syphilis. So these are common patterns which we can easily identify. These are some of the common. Why has this got stuck? And there, I think there are some overlap of the slides over here. Can you please just check my presentation? But in the meanwhile, while they're checking it, I will anyways will be ending this talk. So these are some of the common patterns which we can very easily identify just based on a good clinical evaluation, and that is something which as ophthalmologists all of us need to do. All we need for these diseases is a good indirect ophthalmology and a good clinical evaluation. Thank you so much.
Mudit, one question, very good talk. Would you have a certain guideline for management of retinitis versus management of choroiditis? A broad outline for a comprehensive ophthalmologist.
All right, so broad outline like is the first step is number 1 to identify whether you are dealing with infective or non-infective. Once you are there, for all of our patients, essentially we do get a few tests done for every single patient. You do not have to get every single test done which is available, but few tests are absolutely essential. Number 1 is serology for HIV. The reason is not because you are suspecting HIV in all diseases, but also the fact is that you will be treating these patients with long-term steroids even if they are non-infective. So if they are non-infective, you may be treating them with steroids or subsequent immunosuppressive agents. Therefore, it's important to get a serology done for HIV also, not because of the underlying disease, but otherwise. It's also important to get testing done for syphilis for every single case. Syphilis is such a big masquerade that it can present with any form of lesion. It can present with AC inflammation, anterior uveitis, keratitis, choroidal lesions, choroidal granulomas, retinitis, ground glass retinitis. All patterns of uveitis can be a manifestation of ocular syphilis. and therefore it becomes important for us to get a testing done for syphilis for every single of these cases. Once you have done that, now you know that you are dealing with other diseases, and then you can tailor your investigations accordingly. So if you are thinking of choroiditis, usually we do get them investigated for tuberculosis, number one. The second cause of choroiditis also happens to be sarcoidosis. So we do get a contrast enhanced CT done for most of our cases if our patients can afford it. Remember, not a chest X-ray or an HRCT, but a contrast enhanced CT is the investigation of choice in these cases. That can in often a lot of cases help us in deciding whether we are dealing with a sarcoidosis also. And then you can start your treatment accordingly.
Good, thank you.
Dr. Mudit, what is the test for syphilis now that syphilis is making a resurgence? Which is the one test for syphilis that you advise?
So the two tests which are commonly available, which most people get done, are the non-treponemal and the treponemal test. Both of them are very easily available in most of the labs. So the non-treponemal one is VDRL, the treponemal one is TPHA. The test to be done ideally should be a treponemal one called TPHA. The reason is that TPHA has got a very high sensitivity and specificity for syphilis. So if you've got a TPHA positive, and TPHA is a 94 to 95% sensitivity and specificity for syphilis. So get a TPHA done. Also a VDRL. VDRL is useful to monitor the response to treatment. So a clinical resolution of lesions along with a 4-fold reduction in titers is the definition of clinical cure for syphilis. But to identify the disease, if you have to ask me what is a single test you will do, that should be a TPHA. That should be done for all of your patients.
Thank you.
Thank you so much.
Okay, the next talk will be by Dr. Abhilasha Bahrani, cataract with uveitis, what to do. Dr. Abhilasha is a senior uveitis specialist at New Retina, Hyderabad.
I thank Dr. Bali for this kind opportunity. Thank you, Dr. Malika Goel, for the kind introduction. I'll speak on cataract surgery in uveitis. Most of the time, this is the picture that we see. So cataract is the most common surgical indication in uveitis. It accounts for 40% of visual loss in these patients. 1.2% of all cataract surgeries are in uveitic eyes. About 60 to 80% eyes achieve a BCVA of better than 20/40. However, post-op best corrected is 1 to 2 lines worse than non-uveitic eyes. So in this talk, I'll cover preoperative assessment and preparation, intraoperative challenges and technique, and postoperative complications and management. So we have to juggle a lot of things when we are planning cataract surgery in these eyes. So preoperative preparation and risk assessment is most important. When there is no view of fundus, get a B scan done. Of course, we have to look for the vitreous if there is no cells in the vitreous, but also look for choroidal thickness, which is an indicator for activity of uveitis. Assess the visual potential. Look at the optic nerve. This is a case of multifocal choroiditis with optic neuropathy. After healing, there was a slight pallor in the disc, and when we did fields, you see a centrocecal scotoma there. So this has to be informed to the patient beforehand. This is another case of intermediate uveitis, and while we are busy looking at the snowballs, we might miss the glaucomatous disc here. So get a fields done, and before planning surgery, all this has to be informed to the patient. Pupillary response and color vision should be checked, especially if the patient is on anti-TB therapy. Assess the macula, look for scar. Wherever possible, as much as possible, get an OCT done. Look for a CME, ERM, and you might even see a full thickness macular hole in these eyes. Now, post-operative hypotony is more difficult to manage than increase in IOP. So the indicators of post-op hypotony are intraocular pressure less than 6 millimeters even when the eye is quiescent. When there is seclusion pupil with a normal IOP, please get a UBM done. If you see ciliary body bands or fibrosis, please plan a vitrectomy in these eyes. When the inflammation is poorly controlled, then these eyes are also at risk of post-op hypotony. Timing of surgery is important. Ideally, the eye should be quiescent for 3 months, but this does not apply for Fuchs uveitis. If fundus is visible, wait for as long as possible for full control of inflammation. Please delay the cataract surgery as much as possible. If the patient is having even 6/9, 6/12 vision, we can wait to do the surgery in these eyes. Early cataract surgery is preferable to assess and manage posterior segment pathology and when advanced cataracts pose greater surgical challenges. Counseling is paramount. Please give realistic expectations to the patient about visual prognosis. Inform the patient that the surgery may take longer than usual and there is a possibility of delayed visual recovery. Many patients think that after surgery they need not take their systemic medications. Please inform them beforehand that uveitis treatment will go on even after surgery. So compliance is important. They should come for frequent follow-up. Many of these patients are quite young, and please inform that they'll need reading glasses after surgery. They should not be surprised that the reading vision is gone. So coming to preoperative preparation, steroid prophylaxis is for those who are at risk of macular edema or a recurrence or a hypotony. Step up systemic immunosuppression 1 month prior to surgery. Oral steroids should be given 1 milligram per kg starting 3 days preoperatively, and they should be tapered to the preoperative levels at 1 month. Local steroids, intravitreal or posterior subtenon or intravitreal DEX implant can be given when the uveitis is unilateral and when you know the etiological diagnosis. Please avoid local steroids in the absence of an etiological diagnosis of uveitis. So absolute and long-lasting control of ocular and systemic inflammation is most important in these eyes for satisfactory results. Do not forget to give prophylaxis for infectious uveitis like toxoplasmosis and herpetic uveitis, which tend to recur after cataract surgery. Choice of surgery is obviously phacoemulsification because it causes less inflammation. When cataract and glaucoma coexist, cataract surgery should be done first, because if a combined surgery is done or a glaucoma surgery is done first, the inflammation from cataract surgery can result in failure of the bleb. If cataract and retinal problems coexist, a combined surgery can be planned. Anesthesia is surgeon choice, but do not do these surgeries under topical anesthesia because there you can get surprises intraoperatively. I prefer subtenon anesthesia. It can be given with a single port cannula. So here you just see, this is very simple. You just go into the subtenon space and you can just go with that blunt cannula and inject. So this is a painless block. Now, what are the intraoperative challenges and techniques? Of course, the pupils are small, AC is shallow, you get posterior synec, peripheral anterior synec. You have to deal with all these problems, and surgery should be planned properly. I'll show two cases. I'll show two eyes of the same patient. In one, I have used iris hooks, and the other, I have used B-hex ring. So this is the first eye where I have used iris hooks. So you release the posterior synec. So I have planned a diamond configuration for the iris hooks, because in a square configuration, the iris gets tented and your instruments repeatedly get stuck. So iris hooks should be tightened sequentially, not all at once, because that might result in large sphincter tears. So here you see this is a diamond configuration. I am sequentially tightening this. In a square one, the iris gets tented and maneuvers become difficult. So the main port is above the plane of the iris hook. Phacoemulsification is as usual. Removing the iris hooks is straightforward. The rhexis should be large enough so that you don't get post-op synec again. Viscoelastic should be removed thoroughly from the bag from behind the IOL as well. I'll show some complications of iris hooks. This is a video by Dr. Aroop's hospital. So here there is iris hook has punctured the anterior capsule and there is mushrooming of fluid in this cataract. So the iris hooks are tightened too much. Now again here the iris is tented and the chopper has damaged the iris and there is bleeding. Yes, now you see the bleeding there. Sorry, I need 2 more minutes. While removing the iris hook, one part of the iris gets caught. So please be gentle in these eyes. Now this is the second eye of the same patient. Here I have used a BHEX ring. BHEX ring is a disposable device which has got notches and flanges. You have to do stretch pupilloplasty, inject viscoelastic over and under the iris. And the notches have to be engaged into the iris. This was my first case, so this is very easy. This is much easier than iris hooks. Again, removing viscoelastic from the bag. So comparing the two devices, iris hooks and BHEX ring, pupil size and shape are comparable, but the shape is better in the BHEX ring. There is a little learning curve with the BHEX ring. Surgical maneuvers are easier with BHEX ring. Surgical time is also shorter with that. However, the post-op pupil size is smaller with BHEX ring compared to the iris hook, and post-op astigmatism is comparable between the two devices. Now, this PI or no PI is a question that is often asked. So clear corneal phaco with a large continuous rhexis without surgical PI is the preferred technique. However, in pediatric uveitic cataracts, PI helps in preventing glaucoma. A Cochrane review has shown that acrylic IOL or heparin surface modified PMMA IOLs result in better visual outcomes and lower post-op complications than silicone or unmodified IOLs. Multifocals should best be avoided. Now, IOL or no IOL in pediatric eyes. So post-op aphakia in younger children are associated with better long-term visual prognosis. However, if you are using acrylic IOLs or heparin-modified IOLs in good, well-controlled eyes, IOL is not a formal contraindication. And in one study, 80% eyes achieved visual acuity better than 6 by 9.5 when uveitis was quiet for at least 6 months. The most common complications that have been reported are PCO, glaucoma, and CME. Post-op complications and management. So post-op inflammation can be avoided by aggressive topical, oral, and periocular steroids. NSAIDs should be added. Posterior synecdoche can be prevented by using homatropine and keeping the pupil mobile. So the principle is to over-treat and relax, and don't under-treat uveitis and then try to catch up post-operatively. PCO and capsular phimosis are also common. So a large circular rhexis can prevent it. Hydrophobic acrylic IOL with square edge design is better than hydrophilic. A meticulous removal of viscoelastic and good control of post-op inflammation. Last 2 slides. Now, post-op CME, incidence of CME in uveitic eyes with well-controlled inflammation for more than 3 months is comparable to non-uveitic eyes. The risk of CME is 6.7-fold higher in eyes with previous history of CME. And CME is more common in Behçet's uveitis, and the mean period until development of CME in these eyes is 7 months. And the risk can be reduced by topical NSAIDs. So to summarize, etiological diagnosis of uveitis is key for well-controlled inflammation. The timing of the surgery should be appropriate. Don't be in a hurry to operate. Counsel regarding the visual prognosis, and intraoperative challenges can be tackled by well-planned meticulous surgery, and post-operative care is most important. Thank you.
Well, very nicely explained. You've talked all about the uveitis and cataract. All I would say is that the surgery is easy. All we need is to properly plan. The eye should be quiescent, and we should give a good peribulbar block. And do everything. There should be no shortcut. Then the results are fantastic. You also need to monitor for post-op inflammation. There are times when you can have iris Bombay formation, and patients, pressure can rise up maybe in 3-4 days after surgery. So you need to be careful at that time. That is the time when you have to do a PI, and you have to create a balance between steroids and inflammation and creation of synecdoche. That's it. Thank you.
Dr. Abhilasha, how often have you used or advised use of steroid implant, DEX implant, during the cataract surgery?
Yes, thank you, ma'am, for that question. I generally don't combine steroid implant with cataract surgery because, as I said, there is no hurry to do surgery in these cases. So if I'm planning surgery, I know beforehand. So there are cases of VKH, which can become very aggressive after cataract surgery. So I give the DEX implant about 3 to 4 weeks before surgery.
Okay.
But I don't plan it on the same time.
Okay. Thank you very much. So now we'll invite the chief instructor of this course, Dr. Tinku Bali, who will speak on OCT, what an anterior segment surgeon should know.
Hello, good afternoon, everyone. I'm sorry we had to reschedule the talks a little bit. I had a parallel session. So this was the first talk of the session. This is on OCT, what an anterior segment surgeon should know. Well, we all are now dealing with OCTs. We all should know how to interpret, and most of the anterior segment surgeons do get an OCT done before cataract surgery. So I'll just give you quick tips on how to interpret OCT. We all know that it is an optical biopsy of the retina, and it very well depicts the layered anatomy of the retina. Now, there have been a lot of changes in the OCT over the years, and now it's become very high resolution OCT is now available, with 3D rendering also is available. So when you're seeing the OCT, you see the quantitative analysis and the qualitative analysis. So the quantitative analysis gives you the thickness of the central subfield area. So the central subfield thickness there you can see, that is the most important area that we concentrate on. The qualitative analysis is when you look at the different layers of the OCT. So this is the colored printout. Most often it is better to look at the black and white picture because it delineates the layers more clearly. Can I have a pointer, please? The audiovisual people. Pointer. Okay, so these are the, a laser pointer. Okay, sure. Yeah, okay. So this is the external limiting membrane. The layers that we have to watch out for is this layer here. So this layer is called the ellipsoid zone. Earlier it was called the photoreceptor integrity line or the IS-OS junction, but now it's called the ellipsoid zone, and this is the line which is most important for good vision. Above that is the external limiting membrane, this lighter light that you see here, and this thicker line here is the retinal pigment epithelium. So these are the three important layers. Apart from that, the nuclear layers appear darker in color. So you see here the inner nuclear layer, the outer nuclear layer, these are the darker layers, and the lighter layers are the plexiform layers. The topmost is the nerve fiber layer and the internal limiting membrane. So most often we will be looking at the retinal pigment epithelium and the ellipsoid zone. Now, wearing diseases affect various wearing retinal layers. So, vascular disease generally affects the inner layers. Choroidal diseases generally affect these outer layers. Now, whenever we see the OCT, we don't usually look at it layer by layer. We just look at the pattern on the OCT and make an interpretation in our mind. So, if you see the second picture, you see a little cystoid space here. Here you see an asymmetrical edema of the retina. You see one side there's no edema, one side is swollen up. There you see a lot of cystoid edema here, a lot of intraretinal cysts, also a subfoveal fluid collection here. Here you see some subretinal hyperreflective material. This is a pigment epithelial detachment where you see the RP is lifted up. So just by seeing these cases, you can make a diagnosis in your mind. So this is a diabetic. The second one is a diabetic macular edema. This lower picture is very typical of a vein occlusion where you get an asymmetric edema on both sides of the only one side of the fovea is swollen. That is a post-op CME, an inflammatory CME, and a wet AMD. So this lot of PEDs with intraretinal edema is AMD. So you don't have to look at it layer by layer. If you know the picture, you can make a diagnosis. So again, this is the anatomy. Now, one thing that people often get confused about is subretinal fluid versus a pigment epithelial detachment. So this is the RPE layer here, and this, as I said, was the ellipsoid zone. And fluid here, in any fluid below the retinal pigment epithelium is subretinal fluid here. So if you trace these two lines, I don't have a pointer, so I'm not. If you trace these two lines, you'll be able to make out whether it's subretinal or it's a pigment epithelial detachment, the pigment epithelium which is lifted up. So you just have to trace those two lines and see. Like here you see the RP is lifted up here. So this is a pigment epithelial detachment. This is a combination. You see the pigment epithelial detachment here. The pigment epithelial layer is elevated. Also there is fluid below this ellipsoid zone. So it's a combination. So what is this? Subretinal fluid or PED?
Subretinal.
Subretinal. So you can see that the RP layer is intact, and you can see that that's the subretinal fluid there. So again this, you see the RP layer is intact. The pigment epithelial layer is intact here. This retina is elevated. You see the ellipsoid zone is elevated, and this is some fibrin material which is present below that. So this is again this is SRF. This is not a pigment epithelial detachment. This is the subretinal fluid. Now again, by looking at the, just an interesting thing, by looking at the OCT you can make out whether it's the left eye or the right eye. So can anyone tell me which eye is this?
The disc is on that side.
So the nerve fiber layer is thickest near the optic nerve, and you see here, this is the nerve fiber layer, the outermost layer. So just by seeing this OCT, you know that this is the left eye of the patient because this is thickest near the optic disc. So when you see an OCT, first of all, you have to determine the overall scan quality. The quality should be good, otherwise you'll not be able to see the structures. Now, reading an OCT is like reading an ultrasound because superficial structures affect the underlying tissues. So these lines here, you see these vertical lines, these are shadows of the blood vessels. They are absolutely normal, and these are shadows of blood vessels, which is causing the deeper layers to be obliterated. And that is a pigment over there that is causing shadowing. So just like an ultrasound, here you see shadowing present. Also the layers where there is atrophy, you start seeing more of the choroidal layers. If there's atrophy of the pigment epithelium, you see more of the choroid. If there's any pigment deposition over there, then it will obscure the deeper layers. So like here, there's scar tissue, it's obscuring the deeper layers. Then see the overall scan profile. First see if there's a pigment epithelial detachment and what kind is it? Is there any fluid below it, or is there any fibrous material? Is it fibrotic, serous, hemorrhagic? Then see whether there's a retinal detachment, whether there's any subretinal fluid. Then see for retinal thickening, whether there's any intraretinal cysts, and then look out for retinal thinning. So this is a typical picture of wet AMD where you see these multiple pigment epithelial detachments. There is some subretinal fluid also over here. This is the pigment epithelial detachment, and this is subretinal fluid. Very typical picture for an AMD when you see these large pigment epithelial detachments, and these are not serous because there's this material below it. So this is called subretinal hyperreflective material. This is again a feature of AMD, where you see this hyperreflective material below the retina. Now this is an OCT of a CSR, where you again see a combination of a pigment epithelial detachment. Now sometimes you may confuse this. You may ask that what is this line here? If the pigment epithelial detachment is there, the RP is lifted up, then what is this? So this is the Brooks layer. This is the choroidal layer here, but you see that this is more white as compared to this. So there's no need to get confused. And this is the subretinal fluid here. A branch retinal vein occlusion, I said, was always show edema on one side of the fovea, always. So this is a very, just by seeing this OCT, you can say it's a branch retinal vein occlusion. Again, you see there is shadowing because of the blood in the intraretinal layers. There's shadowing of all these layers here. And this is intraretinal fluid. These are cystic spaces in the retinal layers. So this is a branch retinal artery occlusion. Again, this is a typical picture of a arteriolar occlusion, where you see this dark area here due to ischemia. As compared to that side, since it's a branch occlusion, this is a very typical picture. Whenever you see this, So thinning, again, you see on one side, this is the normal side, the side which is circled, and the other side is thinned out. That also you can see on the OCT. The normal foveal contour, I'll just take some more time. The normal foveal contour this is how you also assess the normal fovea. So there is this structure here, below the fovea, this little uprising here. So a lot of residents come to me and say, ma'am, is this something abnormal? This is absolutely normal. It's the normal foveal peak. The outer segments are thinner and longer. So the outer segment band appears to form a peak. It may not be present in all patients, but it's an absolutely normal finding. So see the fovea and see whether it's deformed or not. There could be an epiretinal membrane, there could be a lamellar hole, there could be a full thickness hole. And when you see the OCT, make sure that the cut has gone through the fovea. So many times when technicians or optometrists do it, they do not take the cut through the fovea. And then you may not get the complete information. After that, look at all the different layers, the posterior vitreous face, the vitreoretinal interface, the neurosensory layers, the ellipsoid zone, the RPE, and the choroid. You can identify additional structures, like I said. The vitreous can also be seen on the OCT. Vitreomacular traction is when there is this kind of a membrane. The vitreous, the posterior hyaloid, is stuck to the retina and pulling on it. So this is very often seen whenever, if you're planning a cataract surgery, because clinically you'll not be able to identify a vitreomacular traction. It's only on OCT that you're able to identify this condition. So any patient of cataract, it's always well worth to do an OCT, and many times you'll be picking up epiretinal membranes and vitreomacular traction so that you can tell the patient beforehand that you may not get very good vision or you may not get optimum vision since you have this condition. Again, epiretinal membranes, through a cataract, this kind of a fundus image may look absolutely normal, but when you do an OCT, this is what you see. Diabetic macular edema has different, there are different types of diabetic macular edema described. Again, this is something about the ellipsoid zone. Like I said, the ellipsoid zone is something before cataract surgery, you should look at it. The ellipsoid zone, this line should be continuous. If it is missing here, especially in the central area, it correlates with the visual acuity, and you should tell the patient that you may not get very good vision after cataract surgery. So always look at this line before you, to prognosticate the patient. Again, this kind of where you see the ellipsoid zone is missing completely. That line of photoreceptors is missing. This is the external limiting membrane, the thinner line here. So again, you can prognosticate and tell the patient. So again, some pitfalls: that retinal thickness, do not compare it between two different machines. Look at all the images. Like I said here, this has been done by a technician, and you see the subretinal fluid over here. This patient actually had a branch retinal vein occlusion. So it was not this. Here it looks like a retinal detachment. Don't rely only on the retinal thickness. See all the scans. And in conjunction with a clinical examination, an OCT helps us with better diagnosis, classification, and monitoring. It should be done for all patients undergoing cataract surgery if possible. And it can also be an educative tool for patients. Thank you.
Very good images, Dr. Tinku Bali. Thanks. I will invite Dr. Ashish Lal to speak on intravitreal injections, how anterior segment surgeons can add it to their practice.
For intravitreal injections, you should have a good grasp on OCT and fundus photography, and you should be able to diagnose the disease so that you know when the fluid is going up and when it is going down and when you can give injections. Dr. Tinku has very nicely explained the OCT, so you have to try and see all the diseases and make an algorithm of all the diseases as to how you need to treat them. So as anterior segment surgeons, cataract we are doing. But if we know how to interpret OCT and we have a fundus photography, this can help us in our diagnosis and treatment. These are very common ailments we see in our day-to-day practice. The availability of posterior segment surgeon is questionable at times. So technique is simple, easy to administer, good money, and wow results. Now, intravitreal injections are used usually in these three conditions. One is the vascular diseases like CRVO, BRVO, or any vascular leakage in macula. Choroidal diseases like IPCV or CNVM, and emergency situations like endophthalmitis. I'll be showing you the technique of this. Now, before that, you need to have a good history, good consent, good diagnosis. They are single patient trials like Razumab, Eccentrix, Osiva, or Eylea, or multiple patient trial like Avastin. So I'm just showing you the step-by-step technique. You need to open this. The injection comes like this. So once the injection is opened, you have to take out the injection. 0.05 ml is what we need to inject. Once we've taken it out, we remove the air bubble, and this is how we do. We put a betadine drop, measure 3.5 mm. This is the video taken from outside. And what I want to say is that your needle should be directed into the core of the eye. You need not see the inside of the needle, and you can even ask your assistant to just inject as you keep the syringe stable. Once it is done, you remove the syringe and just try and put the conjunctiva back. This is the surgeon view. Again, I would like to say that this is 3.5 mm. Just mark it with betadine. Just, you can see here, we are just going inside, directed into the center, and we can see the flow of this is how you need to put the conjunctiva back. We need to see whether there is any vitreous wick coming out of that, that hole. In case it is there, we can cut it. You can see here again. Sometimes there can be a subconjunctival hemorrhage. You need not worry about it. You should tell the patient there and then there can be some redness in the eye, which the patient should not worry. You can see here there's a thing. Now there is one more injection, that is Ozurdex injection for chronic CMEs, chronic diabetic macular edemas. Now this is very important. 3.5 mm. If it is a pseudophakic eye, you need not worry too much about 3.5 or 3 mm, but if it is a phakic eye, your direction has to be very good and right into the center. As you can see here, we are injecting this Ozurdex. Once we've done this. Now, I had a very interesting patient who visited to me about 15-20 days back, and an anterior segment surgeon who did it for the first time, Ozurdex injection, did something like this. During the injection, the Ozurdex went into the lens. And now I was worried whether it is a PCR or is it from the side. Though when I was looking at the slit lamp, it appeared that there is no PCR, but probably from the side the Ozurdex has come inside. And I was prepared with vitrectomy and everything, but however, I was lucky that everything went on very smoothly. I'll just show you this. We are removing the cataractous lens, and you just see this. Now the Ozurdex bullet has gone inside. I was planning to remove it, but then I shoved it inside the vitreous cavity because the patient was a diabetic, and that was the indication for using it, and the surgery went fine. So we have various indications like CRVO with CME, and now this patient got Resumab. You can see that the OCT clearly shows decrease in fluid. What we need to see is the fluid, whether it is intraretinal, subretinal, or sub-RPE, that the fluid should decrease. Then we can repeat it. Diabetic macular edema, you can see here they respond quite well. Now you need to know when you have to repeat it. So after every 4 to 6 weeks, you need to again do an OCT, see whether there is fluid or not. And this is very disease specific. For all diseases, there are different algorithms that you need to have in mind so that you can tell the patient accordingly. Again, this is okay. So learn the indications, make algorithms, disease specific, when to inject, when not to inject. And now a last video for people. Sometimes we have endophthalmitis. We need to know the basic steps as to how to inject the antibiotics. This is a 2-port vitrectomy with valved cannulas. My anterior segment surgeon is only doing it. You can see I have put the 2 trocars. Now I'm putting the infusion cannula. Now looking inside the eye just to see the opening. First, I'm taking out the undiluted sample. Then I start the vitrectomy, take out a dilute sample. Now, these 2 things are very, very important because that will aid us in the diagnosis and the treatment further up. Now, I'm doing an AC wash. And once I've done this, I just go inside. Now, core vitrectomy is nothing. You go inside and do vitrectomy for 3-4 minutes, just like this. Your job will be done. You will have ample of space. And now I'm giving the injections. The injections you need to know which injections are required. And so you can see here that just by 2-port vitrectomy, we have done a core vitrectomy as well. We've taken a vitreous for the biopsy, and we have not even given any injections. So this is something that all anterior segment surgeons should know. So intravitreal injections are like cataract surgery. We all should know the technique, the indications, and obviously how to follow these patients. Thank you.
Dr. Lal, very good videos. Do you check after the, would you advise them to check the hand movements after the injection so that there's no CRAO from increased volume and IOP?
Ma'am, I usually don't do this, but what I do is that I just check the pressure. And the pressure should be okay. With one injection, usually I've never seen that the pressure goes so high. But for like endophthalmitis, I never give injections, 3 injections into the eye, just because of this pressure. So that is why I do, for all my endos, I just put these 2, ports, go inside, do a little bit of core vitrectomy, have some space, and then give injections.
Okay, but safer side, I would suggest that check the vision in the injected eye. At least they should be able to see the light or your hands. If there is no light perception or hand perception, it could be very dangerous. Next, the patient may come with CRAO, which cannot be reversed, that vision loss. Not in my own cases, but I've seen patients like that. Especially in glaucoma patients, would you suggest a paracentesis first if the disc is already very bad? Would you like to do that?
Ma'am, that can be done. That is a good thing.
Yeah, so on glaucoma patients, we can advise them to take a Diamox on the day of surgery or use their regular drops. But if it's a very severely compromised disc, they may not be able to tolerate even that small period of high pressure. So it's better to do a paracentesis and then inject.
And you need to know the volume of injection. It is actually 0.05 ml, not even 0.1 ml. So for glaucoma patients, you need to be more accurate. For brolucizumab, like patients which can be harmed because of more volume, there you should be more careful.
Yeah. And once you've done the paracentesis, it's important to make sure that the paracentesis is not leaking. I've seen end-off happening through that small paracentesis also. So if you can avoid paracentesis in normal patients, it's fine. But in glaucoma patients, yes, paracentesis can be done.
But even post-injection, if they can't see the light, then you have to immediately do a paracentesis.
Yes, yes.
And they start seeing immediately.
True, true.
Great. Thanks. Thank you for the great videos. We'll invite Dr. Tinku Bali again to speak on diabetic retinopathy for the anterior segment surgeon.
So any questions from the audience will be most willing. You can please make it more interactive. If anyone has any questions till now, we look forward to your questions. No questions?
Anything from the audience for any of the talks? Nothing.
On injections, are you all, are the anterior segment surgeons giving intravitreal injections or no? Already giving. So any challenges or anything that you face? I think it's more the decision making rather than the technique of injection. The technique is simple, it's just the decision that when do you have to inject, which injection to give. I think that becomes a little confusing. That becomes confusing for the retina people also now that we have so many choices of injections, when to switch, when to give. So I think it's the decision that is more confusing rather than the technique of the injection. And I think everyone should know the technique of intravitreal so that whenever you have an end-off, you can immediately give an intravitreal injection at least before you refer the patient for a vitrectomy.
But mostly they will not give for end-off. They will give for a diabetic retinopathy and Avastin and send, but not for an end-off. They will just send directly.
But there are times when it's evening time and the doctor is not available. In fact, this video, I was not available and we had an end-off. So I just instructed my anterior segment surgeon that you do this, and give it. So at that time, you just can't, call up people and that doctor should be available, that center should be ready and running. That's a lot of things.
Right. In fact, you should always have a kit ready with you, with the needles, syringes, the intravitreal medicines. They should always be available because you never know when you might need to give. So you must have a stock of the antibiotics in your OT all the time. Okay, so I'll move on to diabetic retinopathy. I'll just be giving you simple tips and certain pointers to manage because diabetic retinopathy is a very vast topic. There's so many aspects to be covered. I hope I can do it in good time. So as you know, diabetes is, it's an epidemic. It's reached epidemic proportions in the world, more so in India. And if diabetes was a country, it would be the third highest populated in the world. So we all see diabetic patients day in and day out. And it's important to know how to deal with this condition. Now, if you go by statistics in India, the prevalence would be around 20% of the patients would have diabetics would have diabetic retinopathy. And after a patient has diabetes for 20 years, a type 1 diabetic would have almost 99 or 200% of the patients would have some amount of diabetic retinopathy, and in type 2 it would be 60%, so 20 years down the line. And the more the number of years the patient is diabetic for, the chances of having retinopathy goes up. So this is how important it is for us and for the patients. Now, a diabetic has a 20 times more chance of becoming blind as compared to his non-diabetic counterpart. And this blindness is largely preventable. And the onus is on us to recognize the diabetic retinopathy and to treat it or to refer the patient. So the first thing that when you see a diabetic retinopathy is to advise the patient. So now here we are not seeing just the eye of the patient. This is one condition where we have to see the patient in totality. We have to see what is the sugar control, what is the hypertensive status, the lipid profile, the HbA1c should be less than 7, the BP should be well controlled. So you have to advise the patient, see if the patient is anemic or not, because anemia again contributes to increase in the retinopathy. Does the patient have any nephropathy coexisting? So you have to see the patient as a complete whole. And it's just when you advise these patients control of their metabolic condition that the diabetic retinopathy also gets controlled. So this is a patient who had retinopathy, and just with systemic control, you see his retina looks so much more cleaner and neater. So when you see a patient, please do emphasize this. Don't just keep seeing the retina. Advise him the other investigations as well. Now, the follow-up schedule is that when a patient has normal-looking retina, you can follow this patient annually. Mild retinopathy is every 9 months. Moderate retinopathy is 6 months. Severe NPDR has to be very closely monitored, 2 to 4 months. If a patient has macular edema, then again every 2 months. PDR, again every 2 to 3 months. And in case you've treated the diabetic retinopathy, then you can monitor 6 monthly or even yearly if you feel the patient is stable. So very mild NPDR, at least 5 to 10% of the patients will develop diabetic retinopathy, so an annual examination is fine. Mild to moderate, I've already told you. Now, this is the time when the patient has moderate retinopathy that you can ask the patient do a color fundus photograph so that you can compare the different visits. You can ask the patient to get an OCT done. So the OCT is going to give you a lot of information. You can identify vitreoretinal interface abnormalities, whether they are present or not, apart from the configuration of the edema present. Now, an angiography is always desirable in these cases. First is to identify any treatable lesions. That is, you may be thinking the patient has NPDR, but the patient would have some new vessels which are picked up by the angiography. To detect any ischemic areas, that is capillary dropout, and to detect enlargement or distortion of the foveal avascular zone. So this is a patient, this is only picked up on angiography. Even clinically, when you see at the macula, you'll see these white vessels. So this gives you an idea that the patient has ischemia at the macula. This patient will not have very good vision, and you can tell the patient that your macula is so ischemic. And when you do the angiography, you can actually see how ischemic the macula is. So in this, the patient may not have any edema on the OCT, but the patient will have very poor vision because of the ischemia. Now, OCT, again, you can see, like I showed you in the previous, you can see a disruption of the ellipsoid zone. So these patients, again, you can prognosticate and say they will not have a very good outcome. Now, drill is another condition that nowadays we are talking about, where you're not able to distinguish any of the retinal layers. There's a disruption in the inner retinal layers as well. And again, these patients may not have very good vision in spite of all your treatment. Now for macular edema, the term that we now use is center involving DME, as opposed to CSME that was used in previous years. Now the definition of diabetic macular edema has evolved because we moved from lasers to injection. And foveal center involving or center not involving diabetic macular edema is what we talk about. So if you see, CSME was these three conditions, but center involving would only consist of macular edema in the within 500 microns of the fovea. And this would all come into non-central diabetic macular edema. So for non-center involving diabetic macular edema, we can still do laser photocoagulation. So we can do a focal laser to the microaneurysms if they are present beyond 500 microns, or you can do a grid laser to areas of the thickened laser. So a laser is done in a grid form here. So this is extra non-center involving DME. But for center involving DME, the treatment of choice is anti-VEGF injections. So how to give these anti-VEGF? You can start with 3 injections which are given monthly. Now different people have different protocols. Again, in a diabetic, it's very difficult to give you a protocol which will apply to every patient, because every diabetic patient is different, his systemic status is different, so you have to tailor your treatment to the patient. But you can give 3 injections and then give these injections as and when needed. They make the macular edema go away. But again, you have to tell the patient right in the beginning. What I tell the patient is that your vessels are like a leaky pipe and the water is flowing out of those pipes. The injections will only absorb the water, but the pipe is not going to be repaired and the water will come back. So you will need multiple injections. The pipe will be get okay only if you control your blood sugar and blood pressure. So that is the analogy that I give to the patients, and they do understand this, and that is how you tell them that these injections will be needed again and again. Many patients assume a 1 injection is a panacea cure for everything, but you have to tell them right in the beginning itself. You can also do a combined approach where you give an injection and you supplement it with laser. And you see these hard exudates and hemorrhages have disappeared. If there is no response to the anti-VEGF, you can either switch to a second anti-VEGF, or what I prefer is to switch to steroids, that is the dexamethasone implant. Especially if the edema is chronic, where there are large cystoid spaces, sometimes I also start with the dex implant in the first go itself. So there's so many injections now, so seeing the patient and the patient's profile, you can decide which injection and when you want to give it. When to stop the injections? When the patient's vision has improved, the foveal contour is normal and their cystic spaces have disappeared. And when do you say there's no further improvement? When there is less than a 10% decrease in the central subfield thickness or a less than 5-letter increase in the visual acuity since the last injection. Now, when you see a patient with a severe NPDR, you should examine him very, very carefully, because these patients will have a very high risk of developing PDR. Very careful follow-up of these patients every 3 to 4 months. You can also do a pan-retinal photocoagulation for these patients, especially if you feel they are not going to follow up. And when you do a pan-retinal photocoagulation, it has to be a full PRP. I've seen people do a segmental PRP. It has no value in diabetics. The entire retina has to be lasered. Now, when you have a patient who you label as severe NPDR, look for venous beading and irmas. Now, irmas are these intraretinal microvascular abnormalities. When you see it with a 90D or even with your direct, you can see that they are present inside the retina. And whenever you see venous beading, like you see here in this picture, the venous beading, this shows you that this patient has a very high chance of moving on to proliferative diseases. So these subtle signs you should watch out for, so that you can follow up these patients very, very carefully, or even do a PRP if you feel the patient is not going to come back. Now, do not see with the direct ophthalmoscope, and indirect ophthalmoscopy is extremely important. Like you see in this case, if you just see the center of the retina, it all looks good. It looks like a mild NPDR. You just see a few microaneurysms here and there. But here in the periphery, here on the nasal side, you see this fibrovascular proliferation lurking here. This patient has a PDR. So a dilated examination, and you see it with the indirect or your 90D also, but not with the direct ophthalmoscope. Now, a patient may sometimes come with symptoms of, he may say, I just have blurring of vision, and you may not see any blood on the first inspection. But put this patient on the slit lamp, and you may see some, like you see for cells in the vitreous, so similarly, you may see blood cells on the slit lamp. And always examine the inferior part. Ask the patient to look down and see the inferior part of the retina. You may see a streak of hemorrhage over there. And these are patients who you will miss. They have PDR, but you will not be able to see it so well. So these are some pictures of a proliferative diabetic retinopathy. Now, for a proliferative, PRP is still the treatment of choice. This laser is done in 3 sittings generally, and the entire retina is covered. So this is, you see here, before laser, this new vessels here. This is after laser, they have regressed. But laser you cannot do if the patient has pre-existing macular edema. If you do a PRP in a patient who has macular edema, the macular edema is going to increase. So if a patient has a proliferative disease along with macular edema, you have to give anti-VEGF injections to the patient. Now, anti-VEGF injections work 2 ways. They also help in regressing the new vessels. They also help in keeping the edema away. So in patients with both the conditions, it's best to go with injections and not do the laser till you're absolutely sure that the macular edema has gone away. Now, in cases like this is an involuted. Many times you'll see patients in the clinic like this. So their macula seems okay, they have reasonably good vision, but they have this kind of a fibrosed kind of a membrane here. So this is a self-involuted PDR. Now, these cases also, it's worthwhile to do a laser, because these patients have ischemia in the periphery, and down the line they may again get new vessels. So it's worthwhile to do, but the laser in these cases has to be very gentle laser. You don't have to go anywhere near these fibrovascular proliferation. Otherwise, they can pull up, and then they can cause the retina to detach. So the laser has to be very gentle. It has to be in divided sessions, and it has to be away from these areas, these fibrous areas. Now, again, like I said, you can also use anti-VEGF injections just to treat PDR. But in the Indian context, sometimes it may be a little, the patient may not be following up very well if you're just treating the patient with anti-VEGF injections for PDR. The patient may not follow up, and then down the years may come. So generally, we do try to do a laser also in proliferative disease. Now, what about anti-VEGFs and vitreous hemorrhage? So you have a patient with vitreous hemorrhage. Should you advise anti-VEGF injection to this patient or not? So before you advise injection, it's very important to do a good ultrasound. So the ultrasound is going to tell you if there is any traction on the retina or not. Patients who have traction, large areas of traction on the ultrasound, those patients should not be given an anti-VEGF, because an anti-VEGF, when you give, it causes again a contraction. It causes fibrosis of that fibrovascular tissue, and it can cause the macular area to detach. If it is not already detached, it can pull the retina up. If you feel that there is no traction on the ultrasound, or if you can see the retina through that hemorrhage and you feel the macula is fine, there's no traction, then you can give an anti-VEGF. Now, what is the rationale for giving anti-VEGF? The anti-VEGF in a vitreous hemorrhage is not going to help in clearing the hemorrhage, but it's going to prevent further hemorrhage from happening. It's going to seal those vessels, the new vessels that are bleeding. And in the meantime, the body will clear the hemorrhage that has already come. So you have to tell the patient that I'm giving you the injection. It's not going to make your blood go away, but it will prevent further blood from coming, and this hemorrhage will gradually clear up on its own. Again, like I mentioned, always treat macular edema before you do any PRP, and anti-VEGFs should be used with caution in cases of fibrovascular traction that threaten the macula. So this is something that you should be very careful about. If there's any fibrovascular traction near the macula, do not give anti-VEGFs. Now, after you've lasered a patient, the patient may still develop vitreous hemorrhage. So why does this happen? So this happens because of a PVD. So many of these well-lasered patients may down the line develop a hemorrhage, but this hemorrhage is PVD induced. So the vitreous which was attached here has separated, and this is how you get the hemorrhage. But these patients, once the PVD occurs, they will do very well. You've lasered them, there'll be an episode of hemorrhage. After that, once this hemorrhage resolves, these patients will have regressed new vessels and they'll do very well. So these patients now, if you've had a PVD-induced hemorrhage, these patients do not require more laser or more injections. This hemorrhage will settle on its own. So now there are certain conditions where lasers, injections don't work, and we have to take the patient up for surgery. That is if the patient has a non-resolving hemorrhage. Now, how do you say it's a non-resolving hemorrhage? Earlier, we would wait for 6 months also, but now with advances in our instrumentation, and if the patient wants, we can operate right away. Generally, we wait a month or 2 months, and then we like to clear up the hemorrhage. Then any PDR, despite your laser, if the patient still has progressive PDR, any macula involving or macula threatening tractional detachment, combined detachments, and vitreous hemorrhage with rubeosis iridis, these are the cases where you take the patient up for a vitrectomy, and that is, so you have to refer the patient to your retinal colleague. So the final points are that metabolic control is very important. For macular edema, which is central, anti-VEGF is the treatment of choice. For non-center, you can do laser. For severe NPDR, you can laser in certain conditions. Like I said, if you feel the patient will not follow up, if the other eyes had a bad outcome, if the patient has very rapidly progressing diabetic retinopathy, then you can even laser severe NPDR. For PDR, a pan-retinal photocoagulation or anti-VEGF, and vitrectomy for TRD or a non-resolving vitreous hemorrhage. Thank you so much.
Thanks, Dr. Tinku, for a very exhaustive, this is a huge topic. To cover it in this way is very difficult, but you did a good job. You mentioned that if there is a coexisting DME and PDR, you would probably give an injection and not start laser. How long would you wait to start laser?
See, if maybe on the nasal side, if I feel that patient has both, till the edema has gone down appreciably, that is the time I would start laser. Not 1 month.
2 weeks.
Even maybe I'll give the second injection and I see that the edema has gone down. It's only then that I would like to start the laser. And laser very gradually on the nasal side, nowhere near the macula, till the edema has resolved to quite an extent.
I would say, Dr. Tinku, that of the two conditions, PDR is much more severe. And the ETDRS and all studies have suggested that in the presence of both, give preference to PDR. So when you're giving an injection, you can start your PRP in a regular manner. Your injection will anyway prevent the exacerbation of the DME. And with these newer strong anti-VEGFs, the last 3 at least, faricimab, aflibercept, and brolucizumab, I think they're so strong that you can start your laser.
Yeah,
instead of
given, it depends if the patient has large cystoid spaces. So once I've given the injection, I know the injection is going to take care of the new vessels as well.
Yeah.
So I'm not that worried about it. If I feel the patient is going to come for follow-up, then I would just keep the patient under observation.
See, for these,
when it has come down a little
correct.
bit.
But for comprehensive ophthalmologists, the message is that PDR is very important. If you give an injection, of course, they'll be all right for 2 months. But after that, what will happen to them? They will be left in the wilderness.
Yeah.
So that's one thing.
That point should be, because there are a lot of patients, they're just injected and they're lost to follow-up. They come back after 1 or 2 years with a vitreous hemorrhage.
With a TRD or a combined.
Yes.
Other thing is, just like injections, we cannot tell a patient that we will be giving you 3 injections for DME or 5. It depends on how the patient requires. Similarly, for laser also, we cannot say 3 sittings or 4 sittings. It really depends till your new vessels on the disc or elsewhere have resolved. And we've had to have 10 to 12 sessions in some cases. So we can say, okay, roughly 3 to 4 laser sessions. But if your new vessels are still there, we'll keep on adding. We'll keep on adding. True. Because otherwise they'll say, you said 3 and now 3 are over and now you still want to do more. So I never tell them. I say, I don't know. I will decide next time when I see you whether I will need or not. Every time they will ask how many more. I said, I don't know. I have to say that. I have to see you and then only I can tell you next time. Also, do you use Octa, or would you advise the use of Octa if they have for determining whether NVD has regressed or NVE has regressed? Sometimes you have a doubt whether NVD is there or not. Do I have to add more laser or not? Do you use Octa as a non-invasive tool?
No, generally not. I don't use Octa. But I would repeat the angiography. I would do a check angiography 3 months down when I've done the laser. I would do a check angiography to see if there are any new vessels still present or not, and then supplement the
So
laser.
nowadays, instead of angio, you can just take the patient to Octa. That's what
Yeah,
we've started doing. So even our technicians are able to do the Octa disc angiography. So very clearly, you're able to see the new vessels in 2 minutes without doing a fluorescence. And that helps me to decide whether we need to add any more laser or stop the laser. Because sometimes you really can't make out the new vessels, regressed new vessels versus fine new vessels. You cannot make out.
Yeah, but for the anterior segment surgeon, the Octa would be a little bit of a challenge to interpret. So for the message to them would be that an angiography should be done. After the laser has been done, a few months, 3 months down the line, you can do another angiography to check whether new vessels are present or not, and then supplement the laser again.
Yeah, angiography, whichever you can do. And you had also mentioned the point where in vitreous hemorrhage, you give an injection so that the hemorrhage is allowed to clear by the body. But also, too important is that in the meantime, while you are waiting, keep adding laser. Otherwise, the anti-VEGF injection effect would have gone, and they will come back with a rebleed. So you gave an injection in vitreous hemorrhage, and as Dr. Tinku said, it is not going to clear the hemorrhage. It's only going to close the new vessel, so you don't have a recurrent hemorrhage. But you have to use those 6 weeks to keep adding laser as the blood resolves. So keep calling them every 2 weeks and keep adding laser as the blood is resolving.
Yes, good point. Any of the audience, any questions?
Is it?
Really? Thank you.
I want to make some points because when following up a diabetic retinopathy patient, please don't rely only on indirect and direct. Please combine all three: slit exam, direct and indirect. Because individual items have their own importance. And regarding injections, I'm using it for a quite long period. Please don't forget to do ECG before applying the patient. Please don't tell your patient it is a very simple procedure, nothing will happen, I will give you the injection, it's a matter of few minutes and you will be fine. Because there are a lot of deadlier combinations, and if anything happens, though rare, you will be in total shock. Because please don't put them in an unexpected future that no surgery is complication-less, zero complication. So this counseling is also very important, that you may develop retinal detachment, may develop endophthalmitis, may develop vitreous hemorrhage. It is very, very, very rare. But if it happens, and if I have told the patient earlier that it is nothing, and we will be in a shock.
True.
Yeah, absolutely.
And informed consent is extremely important, and you must always make the patient sign an informed consent. That is utmost very important.
Yeah, very important. Every injection we have to emphasize to the patient that this is a risky procedure. We are taking a risk in this. You may lose your eye. Almost every injection we have to remind the patient.
If you say you may lose your eye, the patient, then you will lose the patient. If you say that.
But not your freedom from the, Any other queries? People are... For injection, you mean? Dr. Tinku?
No, it's done as a daycare procedure. The patient comes, we give the injection, we put a patch on the patient's eye for 2 hours. So that just because it's more comfortable, we put ointment and we put a patch. It's more comfortable for the patient that way. Ask the patient to remove the patch at home itself. And then we can call the patient the next day. Different people have different protocols. I like to, if they can come, it's better to call them the next day, otherwise after 2 weeks.
What should be the
You should always tell them the symptoms of anything that has gone wrong. The patient should not have any deterioration in vision, any pain or redness. So you must always tell them of these warning signs before you send them. A lot of our patients are from outstation and they go away right after taking the injections. But then they are told about these warning signs to call immediately if something happens. Yeah. Yes, please.
What should be the direction of the bevel for intravitreal?
Bevel up.
towards lens or bevel direction?
You have to go perpendicularly into the vitreous cavity, not towards the lens at all.
Okay.
Perpendicularly down into the vitreous cavity. Bevel up, you can go slightly into the sclera tangentially at around 20 to 30 degrees tangentially. Instead of going straight in, go tangentially a little bit, then turn your needle and go vertically down into the vitreous cavity. So that way you have a more sealed effect of the entry that you've made. The sealing is going to be better if you have a tangential and then vertically down.
Bevel direction?
Bevel direction is not so important.
No, not.
You go bevel up. The bevel should be facing up. Go like direction. You mean radial or?
No, ideally bevel up so that the drug doesn't
Bevel
directly
up
fall
and
on the
then-
macula. But that's not always possible. So you can just give it anyway, but just see that you're not injecting directly.
So which quadrant is preferable? Temporal?
Inferotemporal is the most accessible. Inferotemporal is usually the most accessible, and because of the patient's reflex movement upwards, that is the best also. If you go superotemporal, sometimes patient moves up also. So
Yeah. Also, if you have a little hemorrhage, it's covered with the lower lid. So the inferotemporal or even inferior is fine. Quadrant is not so important. Whatever is easy for you to access. But generally, we prefer the inferior or inferotemporal quadrant.
Thank you.
Sir? 30 gauge needle. 30 gauge.
yes, doctor.
What injection will you give for the macular edema and nephrotic syndrome, I mean renal failure patients, madam? Because a lot of edema will, anemic patients will be there. Glucose is not under control, and a lot of complications are there. And almost the drug is nephrotoxic.
Regarding affordability, we have two options.
Mike is.
Regarding affordability, we have two options. One is use of Avastin, which is a multiple, injection you can give to multiple patients. That is little cheap, but then you have to be very careful about the safety and the,
Medico-legal
infection
aspects.
problems. And because it is not, medico-legally, you can be in a soup in case there is an infection. So I would recommend that giving biosimilars, Indian biosimilars like Razumab, which costs around 8,000, 9,000 rupees the injection. So you can charge whatever your surgeon fees over it. That will give you more peace of mind.
What was your question actually? One is affordability.
No, madam, not affordability. The drug is nephrotoxic and patient is in the renal failure, and dyslipidemia will be there in the renal failure.
Nephropathy is there, significant nephropathy. And what is the injection to give?
No, ma'am, because a lot of macular edema will be there, secondary to diabetes. all
Okay,
these
so
complications
if there
will
is
see.
significant nephropathy, first you need a clearance from your nephrologist that and they don't know that anti-VEGF can damage. So you have to let them know that anti-VEGF may cause some damage to the renal functions. Can the patient take it? Can the patient take that decline? And can you manage if there is a decline? So if the nephrologist feels that the patient cannot take any further deterioration of the renal function, then you can switch to steroid if it's just a DME or a RVO. In AMD, you cannot switch to steroid, but in vascular conditions, you can use steroid then in that case. Yeah? Is that, have you, is
Yeah, ask the
that answering your
nephrologist.
question?
Most of the times, nephrologists, they won't give any opinion on the intravitreal injections. Madam.
That's
the problem.
because they don't know. So you have to tell them that this injection can cause a problem. Are you okay with that? Will you be able to handle that? Can the patient handle that? So they will generally tell that no, this patient cannot. He's already very severely compromised. Or they will say you can go ahead. He is reasonably good.
And how far it is, feasible and safe to start with the steroid, madam, because we know that this drug is nephrotoxic, and patient is already under a compromised situation.
You can give a steroid with the idea that IOP can rise, cataract will form. So those issues are then there are local ocular issues with the steroid. But those are safer than having kidney problems.
Yeah, generally steroids are safe.
Yeah.
It's very rarely that they will cause such a high, rise in IOP. Or even cataract formation with one injection, generally there's no cataract. It's with repeated injections that you get cataract. So I think steroids is a very good option in such patients where
Steroid
patient
means dex implant.
Yeah. Patient is almost, usually they will be on the dialysis, madam. Can we be keeping in that point in view? Can we go for ranibizumab?
Yeah, now this is a very good point. If the patient is already on 3 times a week dialysis, that means there is no renal tissue left. So our nephrologists say that there is nothing left to preserve. Please go ahead and give whatever you want, because already the patient is on external renal management. So if it's very bad, then again there is nothing left to preserve and you can give. But if it is a once a week dialysis, twice a week dialysis, there they may not be able to tolerate. So there you may hold the anti-VEGF or you may give a steroid.
Thank you. Because in our hospital, both dialysis and ophthalmology units are there. At the time of dialysis, anticoagulants are used with the implant. So if your patient is having scheduled dialysis on, suppose on Monday, please avoid giving on Tuesday. You would give on Monday and the maximum possible gap with the dialysis. First day Monday, next day Thursday. Anticoagulant, if it gradually go off, don't give on Friday. Give it on the Thursday itself, and if possible, defer the dialysis by one day or one session, so the ignition comes first.
Yeah, your point is good, but usually I think you're talking about heparin, right? So heparin, the duration in the eye body is only 12 hours. So generally, if it's a post-dialysis, next day we do surgeries also. In fact, we ask for dialysis one day before surgery so that the patient is comfortable on the table. So that's usually heparin will clear out. Next day.
I totally agree. Actually, you don't have to do a heparin-free dialysis. We've had now so many patients, since I'm in a multi-specialty hospital, which has a very big nephro department. So we don't stop the heparin, and we ask the patient to get a dialysis one day prior.
Before surgery.
So that the patient is more comfortable, patient doesn't become breathless on table, systemically better
Unlike
controlled.
antiplatelet agents, where 3 to 5 days we stop.
We don't even, for cataract surgery, we don't stop anticoagulants also. Aspirin, warfarin also we don't. Yeah. So heparin-free dialysis is not actually needed now. We have a lot of consensus on that.
Ma'am, you advise for hand movement after the intravitreal injection. In addition to that, I want to tell that I'll do NCT, non-contact tonometry, after 1 hour or 2 hours after that. And in follow-up 1 or 2 days, again check the way.
See, the pressure rise will be maximum in the first 1 to 2 hours only. So calling them next morning or even after the 48 hours for IOP check is meaningless.
No, after 2 hours.
He said 2 hours. Yeah.
2 hours.
That can be done. A lot of people do that. A lot of surgeons, but then you have to make the patient wait. So generally, if the patient, you don't want to make him wait, you can give him a... Yeah.
See, the IOP will be highest at the time of injection. It's not going to be higher after 2 hours because right now you have injected. So if there is hand movements immediately post injection, very unlikely that it will disappear 2 hours later. Am I wrong?
Yeah. But I noticed that it will be okay after 2 hours. Not a single patient, they have a rise of intraocular pressure after 2 hours.
But you have not checked at the time.
Yeah, vision also checked.
Yeah, we can do whatever we are comfortable with. See, the more the safety we take, it's better for the patient. There's no need to cut corners.
Your expert opinion on the cost of the molecule, madam. One, as we know, Avastin around 10,000, ranibizumab around 20,000. Now some companies come with 9,000, and latestly another company has come with 4,000. So your take on message on that about the efficacy of these injections.
The cost of these injections.
One is 4,500 and another is 21,000.
What can we say about that? The company knows what is their manufacturing cost.
Can we use these 4,500 rupees injections also?
They work. The biosimilars do work. They do. They are efficacious. It's not. But then you have to be sure which company you're using. There's so many companies which have a good track record, who we have experience with. So those are the biosimilars which work.
Cost should not be the only criteria why you choose it, because the efficacy may not be that good if it is very cheap. And as Dr. Tinku said, you should have 1 or 2 to which you are sticking, which have very good track record. Every day there is a new company now coming up. Ultimately, you have to face the music if something goes wrong, not that company.
Yeah, something you have experience with.
With a recent history of MI or stroke, what would be the preferred anti-VEGF of choice?
Steroid.
None in anti-VEGF we can inject?
Yeah, then if you have to give, you have to use the one which has the shortest half-life in the body, serum, which could be ranibizumab. Compared to aflibercept.
How much time can we inject with a recent history of MI or stroke?
Ideally 3 months. Ideally 3 months, minimum.
But is ranibizumab safe enough?
Yes, the safest one might be ranibizumab because it has the shortest serum half-life. But even that, if it is not, DME is not an urgent disease, RVO is not urgent, so these can wait for 3 months. If it's AMD, yes, that probably will cause macular scarring in 3 months, so there you may give it a lower dose if you can.
What about aflibercept?
That is a longer half-life in the body also, and much stronger also, the suppression, VEGF suppression. So possibly that would be more.
But are we medico-legally safe to inject ranibizumab?
use ranibizumab? Yeah.
Yes, legally safe.
Yes.
With a history of MI or stroke.
3 months down the
3
line.
months down.
3 months.
Medical
down the line.
legally, yeah, 3 months probably.
3 months.
Besides, the important part is that these patients
Mike.
are on drugs, so they are already on, preventable things.
Though we don't really keep that hard and fast. I mean, you have to see the risk-benefit ratio to the patient. You can't have a blanket that 3 months I'm not going to inject because you've had a recent MI. It's not a
3 months or 1 year,
blanket
madam,
thing.
which is the safest? Because especially for the ranibizumab.
Ranibizumab you can give.
After 3 months.
Yes.
1 year.
Even during the
before
3
you
months,
can
if you
give.
have to give something, that would be the safest. After 3 to 6 months, anyway, you can choose anything you want. But within the period of risk, ranibizumab might be the least dangerous.
And moreover, anybody who's had stroke or stenting, these patients are on anticoagulants, so they are less risky. Once they are on the drugs and they are compliant with their treatment for stroke and all, then they are little less risky.
Thank you.
Ma'am, in cases of non-center DME, on OCT, we have parafoveal DME. So it is advised, like, what should be the recommendation, like anti-VEGF or strict metabolic control, or the vision
I think
6
this
by
is the
6. In cases of
parafoveal DME,
non-center
how to manage.
involving DME, on OCT, if we have parafoveal DME, if the vision is good, 6 by 6, so should we advise anti-VEGF or strict metabolic control is...
Just metabolic. If the vision is good and there's paracentral, then there's no need for injection.
And on FFA, there's like a sulcidate parafoveally and leaking microaneurysm.
Then you can do a laser
focal
onto
laser.
that. You can do a focal laser so that it doesn't move on to the macula.
Yeah,
Yeah,
the
that's a
vision
very good case for a laser treatment, a focal laser
Even
treatment.
if the vision is 6 by 6 good.
Yes, you can do that. You can do that if you see a large circinate ring, because ultimately it's going to move on to the
Move on to the-
fovea. Yeah.
Thank you.
Okay, so I think
Are anti-VEGF really dangerous or contraindicated in case of the recent history of MI or stroke? Because, the quantity is very less. Is it?
See, yeah, that's a very
medical
good...
legally it's okay that if the patient doesn't give history, in that case, if we, by mistake, we have injected or,
See, that's a very good question. Actually, there has been no clear evidence that these cause any of these events. It's just a very safer side precaution. None of the randomized trials have conclusively shown any relation. But it's just something theoretically we know that when intravenous anti-VEGFs were being given for oncology, they were causing thromboembolism. So we are just taking that data into our intravitreal. And as you said, the dose is so less. So really speaking, there is no evidence actually. So if you have a significant retinal disease that demands the injection, you should give it.
Yeah.
What is the standard protocol post-operative medicines you are prescribing for any intravitreal injection?
Antibiotic, moxifloxacin eye drops. Yeah, that's it.
But I don't
For 3
prescribe
days.
even that.
Yeah,
because-
there are so many people who don't. You may not even prescribe an anti. This is a lot of controversy. What I personally give for 3 days, a lot of people give topical. No anti-glaucoma. No, just antibiotic.
Antibiotics
You
also,
can-
if you're giving repeated injections, you are going to just create a surface resistance.
Yeah, true. So a lot of people would feel more comfortable in
medical
giving.
legally again. Yeah.
Again, medical legally. And patients would also feel more comfortable if they're putting something. Also a lubricant.
Yes.
A lubricant.
Good evening,
And
ma'am.
you can give the patient a Dimox right after if you feel that there might be a rise in IOP. If the patient's nephropathic status is okay, then you can give a Dimox.
Is there any contraindication of the anti-VEGF in pregnancy, or if there is not any contraindication, which anti-VEGF?
That's the single absolute contraindication is pregnancy. That's an absolute contraindication.
Okay.
And no anti-VEGF in pregnancy.
Okay.
That's the only, actually that's the only absolute contraindication.
Absolute contraindication. Or is there any, in pregnancy, should we laser the very severe or severe NPDR patient, or
Laser you can always do, yeah. Even very severe
yeah.
NPDR, if you feel the patient will go into proliferative disease, you can do laser. You can give intravitreal steroids if there's edema, but anti-VEGF, no.
Okay, thank you.
So, thank you so much for this very interactive session. You've been a lovely audience. We've enjoyed interacting with you, and hope it has been a fruitful session for you. I thank all my the speakers, the moderators of this session for being here and answering all the questions, and look forward to seeing you again next year. Thank you so much. And you can always come with your queries later on also. You can always write to us.
Thanks, Tinku, for a very good session, and congratulations on this participation.
Thank you. Thank you.
Thank you so much.
Thank you.